Welcome everyone to the eMedica MRCGP AKT High Yield Revision webinar number 3 for the April 2024 exam. So in terms of the format today, we're going to split it into sort of 3 parts. Throughout, we're going to cover exam style questions covering key topics, followed by rapid reviews and examples. But the way we'll do it, part 1, I'm going to go through 5 questions where you'll see a question, you'll have 55 seconds to look at it, then I'll launch a poll. Part 2, we're going to do a timed mini mock exam. You'll see 10 questions, one after the other. And then we'll go through the answers and explanations for all 10 at the end. Then part 3, we'll talk about revision planning, how to make the most of the last 6 weeks as we come up to the exam. And then if anyone's got any questions, I'll take questions at the end. But the team will take questions throughout the session. So use the chat as you've been doing for comments or to get involved in the discussion. If you've got a question that you'd like myself or the faculty to answer, please use the Q&A, not the chat. Questions in the chat won't be seen, they won't be picked up. But questions in the Q&A will stay there until someone in the team has cleared it. So joining me today from the eMedica faculty, we have Masooda Rahman, Anna Greathead, and Laura Smith. They'll be answering questions throughout the whole evening. And then at the end, anything left will clear up in the final Q&A. Right, so we're going to go straight into it. As I mentioned, part 1, what we're going to do is we're going to do 5 questions, one at a time. You'll see a question. You've got 55 seconds. Then I'll launch a poll. Use the poll to answer. Once a poll comes up, you've got 10 seconds to select something. Okay, we'll do some stats, some admin, some clinical throughout this session. Here we go. Okay, time's up. Very interesting split. So the 2 really popular answers are A and C. They're about equal, okay? Followed by D. The correct answer is A, that the hearing in the right ear is mostly in the normal range. Now, some of you might be wondering, well, which ear is which? There's no labeling. That's part of what's being tested here, okay? When you have a color audiogram like this, the standard denotion is that the right ear will always be shown in red, red, right, and the left ear will be in blue. So this is the right ear, this is the left ear. Another common mistake is people think this is one ear showing both air and bone conduction, and so they think that this is a gap, and they think that this is a conductive loss. Bone conduction is always shown by brackets, so bone conduction just isn't shown in this, and that's typical for sensory neural hearing loss. They don't bother showing bone conduction in a lot of audiograms. It's because we don't really care about it. We care about air conduction. Whereas in a conductive loss, you'll see both bone conduction and air conduction so that you can see the gap. I'll show you an example of it later. Okay, so why is A the correct answer? Well, as I mentioned, look, this is the right ear, right? Let me show you where normal lies. 20 decibels, anything above this is normal, okay? Once we get below this, we've got some mild hearing loss, then we get more serious hearing loss, and then once it gets down here, it goes into severe hearing loss, okay? And so what you see is the right ear, almost all frequencies are in the normal range. Right at the top, above sort of 7 kilohertz, you can see there's just very mild loss. But the rest of it is all in the normal range. And that's exactly what A is, that the hearing in the right ear is mostly in the normal range. Okay. Let me look at the other answer that was really popular, as popular as A was C, that this is consistent with a conductive hearing loss in the left ear. All right. This is the left ear. What we see in the left ear is that there is some loss here, but we have no information here about the bone conduction. So we can't say that there's a conductive loss. And if there was a conductive loss, they would show you the bone conduction. Okay. And then finally, E, that the right ear is normal in the low frequency. You know, if you look at some people, both ears show mild hearing loss in the low frequency. In the low frequency here, the right is completely normal. The left ear has some loss in the low frequencies, but the right ear is completely normal. Okay. So bone conduction is shown with brackets. So either square or triangular brackets, and air conduction with a cross for one ear and a circle for another ear. That's typical. And when you have it in color, the right ear will always be red, the left ear will always be blue. So this is an example of what you might see if someone had a bilateral conductive hearing loss. So look, bone conduction's in the normal range. You've got some hearing loss in both the right ear and the left. The right ear slightly more than the left, but there is bilateral hearing loss here that's conductive because there's a gap, okay? Like this one, in a sensorineural hearing loss, typically they don't bother showing you the bone conduction. Anyone know what type of hearing loss this is typical of? So it's bilateral. You can see both right and left ears are affected. You can see normal hearing in the low frequencies, and we've got mild loss in the medium frequencies. But once we get to the very high frequencies, we've got severe loss. This is typical of presbycusis, the hearing loss of old age. It's typically bilateral. Okay, well done. Okay, let's move on to question number 2. Okay, great. I'll stop you there. So 2 most popular answers are B and D. So B and D. Now, this is a 2-step question, and 2-step questions in the exam can be quite challenging. You can see that the question is asking about most suitable management option. There's a lot of information here. So you can see management is the second step. The first step is to read this big description and think, what's the likely diagnosis? Type into the chat, what do you think is the likely diagnosis? Because in a 2-step question, if you get the diagnosis incorrect, often it can have an impact on your chance of getting the management, the second step, incorrect. Okay. So let's see what people think. Got a range of answers. Most of you think it might be epididymoorchitis. A few people have thought it could be an STI. Some people have thought prostatitis. That seems to be the main spread. Okay, so the correct answer is D. Treat with levofloxacin 500 milligrams once daily for 10 days. So the diagnosis here, this fits with epididymoorchitis. And if you look at the information here, not been sexually active in the last month, but he was recently treated for a UTI. This is important because you've got to think, if it is epididymoorchitis, what could be one of the likely causative organisms? Can it help guide you towards what you're going to use in terms of management? Okay, so something that's really useful here is that there's mild tenderness and Pren is positive. Type into the chat, what's Pren? So an acute history, you can see 4 days, not change much in 2 days, ibuprofen's helping, no trauma. This is all very relevant, but these are the most important bits I've highlighted in blue. Okay, so Pren is when you elevate the scrotum, thereby elevating the testes, and it relieves the pain. It's useful to separate epididymoorchitis from torsion. In torsion, Pren will be negative. The pain won't get better with elevation. Okay, and so how does epididymoorchitis present? Tends to have a gradual onset, like this patient's. It's painful, tender on examination. There'll be a palpable swelling with erythema overlying, and Pren is usually positive. So when you elevate the testes, it relieves the pain. Okay, so how do we manage epididymoorchitis? Well, it depends. If the symptoms are really severe and the patient's sort of, got systemically unwell, very high fever, you might even need to admit them because they might need IV. Otherwise, we can either refer to GU or we can treat in GP if the patient doesn't want to go to GU or they can't get an appointment very quickly. And what you do is you treat based on the likely cause, because you could get epididymolysis secondary to an STI, in which case things like gonorrhea are common. So something like ceftriaxone, that can be useful. You could use doxycycline or azithromycin. Often patients with gonorrhea, they might also have a risk of chlamydia, for example. But see, this patient hadn't been sexually active for some time, and he recently had a UTI. And so with UTI and a low risk of STI, an enteric organism is much more likely, in which case you can either use ofloxacin for 14 days or levofloxacin for 10 days. And that was the right answer, right? Now, ofloxacin was one of the answer options, but the reason it was incorrect, if you look at option C, ofloxacin single dose isn't going to do anything. It's a 2-week course. Do you see? 2 weeks twice daily. You'd only be getting 1 dose instead of 28 doses with this. It's not going to do anything. If you thought STI was likely, then this might be a good option. Okay. If Prensine had been negative and the pain had been much more severe and maybe in a younger patient, and if it was torsion, then you might admit for surgical management. Quite a few of you did pick that. Okay. Let's move on to number 3. It's also a 2-step question. Okay, great. So the 2 popular answers are A and B. No need or offer a delayed script. They're the 2 popular ones. Then a few people picked start penicillin V today. Hardly anyone picked anything else. Okay, so as I mentioned, this is a 2-step question, right? So you can see this patient's presented with sore throat, and the question's about antibiotics in sore throat. And we can see here, the question is specifically testing knowledge of the fever pain criteria. So from this description, the first part is working out this patient's fever pain score, because that's going to give you what is the right management. So let's do that as well as a learning. Type into the chat, what do you think this patient's fever pain score? Because that could be the question. The question could ask you, what's the patient fever pain score? And it could list 0, 1, 2, 3, and so on, right? So we've got a range of options from 1 to 4. So big spread, okay? This patient's fever pain score is 3. The reason being, they've presented within 3 days. That's the A in fever pain is attending rapidly. So they attended within 3 days. They've attended in 2 days. So that's within 3 days of the onset of the symptoms. Okay. Temperature of 38.1 earlier today. So fever within the last 24 hours. It doesn't matter that on examination it's normal. Patient's recorded temperature is okay. As long as it's within 24 hours, that counts. That's the point. That's the fever in fever pain. It's fever in the last 24 hours. Okay. And then the I is for inflamed tonsils. They've got inflamed tonsils, but no pus. Because if they had pus, that would be another point. That would be 4. So because they haven't got pus, tonsils are inflamed, they get 3 points. Okay. They don't get a point for the N. The N is no cough or coryza. And you see, it mentioned that they've got a runny nose. So they don't get a point for that because they've got coryza. So therefore, there's no point for that. So they've got 3. And what does the fever pain guideline say? For 3, 2 or 3 consider delayed script. If it was 0 or 1, the odds of it being a bacterial infection, streptococcal, very, very low. So the guideline recommends no antibiotics. They score 0 or 1. They score 2 or 3, consider a delayed script. If they scored 4 or 5, then you'd consider starting antibiotics today. And then first line is Pen V for 10 days. If they're allergic to penicillin, then you could use erythromycin or clarithromycin. Those are for 5 days. And this patient, there's no mention of any allergy. And you see that's why the correct answer is a delayed script for Penfy. Okay, question number 4, admin domain. Okay, I'll stop you there. So the 3 popular answers are the bottom 3, C, D, and E. Key thing is that this patient, they want access not for their own records, but their father's record who's passed away. They're worried about negligence, okay? So there's a specific act. If someone wants to access someone else's record and they've got legitimate reason to do so, like this person, if they're the next of kin and they think that there's been negligence, they could apply under the Access to Health Records Act 1990. Okay, well done. A lot of you got this right. The common mistake is people pick C. The Data Protection Act is if you want to access your own information. You can't use that to access someone else's information. That's to access your own information. So if one of you wanted to get access to your information held in a medical record, whether it's in hospital or your GP practice, you could apply under the Data Protection Act to see that information. If a company wanted to access information on their employees in relation to occupational health, it could apply under the Access to Medical Reports Act. And then if someone wanted to access information about next of kin, or if they're the executor of the will of someone that's passed away, they would apply under the Access to Health Records Act 1990. Okay, let's look at stats, specifically data interpretation. Okay, great. So the question's asking which area had the worst mortality rate for a specific group, not just mortality overall, but for women under 75. And what you can see here is we've got mortality rate for all causes for all persons, male and female. This is mortality for all causes male. This is mortality for all causes female. And here what we've got is a subset, specifically for cardiovascular related disease, deaths related to that. People that died of a heart attack, people that died after having a stroke, people, specifically cardiovascular diseases. All of these will be included within these because this is death for any cause. Could be a heart attack, could be a stroke, could be cancer, could be an accident, could be, anything. All right. The mortality rate, if it doesn't specify which disease, or it just means death for any cause. Okay. So the first thing is to make sure you're looking for the right line. And once you do that, you're looking for the worst rate. So the higher the number, these are deaths per 1,000 people. Okay. The higher the number, the worse the mortality rate. So all you need to do is make sure you're looking at the right line. So that's under 75 mortality rate for women. And then you just read along here and you look for the highest number. So you can see Doncaster had 324 deaths per 1,000. That's why that's the correct answer for the worst mortality rate. Interestingly, first of all, most of you got that right, so well done. But the second most popular answer was B, Bradford. Now, if you look at Bradford, Bradford didn't even have the second highest mortality rate for women under 75. That was Barnsley. So why might people have picked Bradford? They might have looked at the mortality rate for men, where Bradford was the highest, or just for all causes for persons. This is male and female combined, where you can see 406. It's the highest. It's higher than Doncaster. So just not reading the question carefully, or just looking at, because there's no maths here. This is just data interpretation. This is real life data taken from public health. You can go on the public health website and look at this for your area, for different things, just to get familiar with it. It's worth doing. But, a common mistake would be that people will have just looked at either the male or the persons, or sometimes they might have looked at female, but looked at the cardiovascular disease rather than just mortality. So you're looking at the subset. Because if you look at cardiovascular disease, Bradford had a higher rate compared to Doncaster. So looking at the wrong row would lead you to get the wrong answer. And other types of data interpretation that you should get familiar with: prescribing data, regional disease incidence and prevalence, other types of public health data, which might look at things like different proportion of patients in different age ranges, mortality rates, subsets of that, cardiovascular mortality, infant mortality, cancer-related mortality, but also interpreting research data in graphs and charts, okay? Some of the kinds of things you should be able to interpret. So this is looking at different age groups and the proportion of patients within those age groups in a particular practice compared to the England average. This is look at broad spectrum antibiotic prescribing in a particular practice compared to the England average for different quarters of the year. This is called a quinary graph. It's looking at what proportion this particular practice had of male and female patients in different 5-year age bands, 0 to 4, 5 to 9, all the way up to 95 plus. This is looking at infant mortality in different areas. And then interpreting graphs and charts that you might see in a study. This is called a leaf plot. This one was specifically for looking at pre and post-test probability for COVID based on PCR tests. And there's a Kate's plot, which is a visual way to represent risk. You should be familiar with all of these and more for the evidence-based practice domain of the AKT. Right, any questions so far, type them in the Q&A. But if you found that way of learning helpful and you missed our AKT Masterclass webinars where we learn like that, we do one question at a time, then you do the poll, then we go through answers, explanations, and worked examples. We ran those over the last couple of weeks. So we had a half-day stats covering key stats topics, half-day organization, domain organized, covering key admin topics. Last week, we had High Yield Clinical Grammar 1 and 2. Between those two, we covered 100 plus clinical topics that RCGP examiners have mentioned in recent examiner reports. These things get retested very frequently. Okay, the recordings for all of these have been updated and are now available. So you can book any one. So stats and admin are £125 each. The clinical grammar is £198 for both, or you can get all four as a bundle for a discounted price. Okay, so stats, we went through 45 questions like that, but more than 50 topics, because sometimes after one question, I'd go through many more topics. Okay, and lots of people have gone from fearing or really being confused or disliking stats because they found it challenging to being the area that they ended up getting the best mark in, 100%, 95%, 90%. If you can get a good mark in stats and admin, it really helps you boost your chance of passing the exam overall. Of course, ultimately, you need to do well in clinical too, because that's most of the questions. And then these are some of the topics we covered at the admin webinar. Again, we covered 45 questions, but 60 plus admin topics. Okay. And then High Yield Clinical Grammar 1 and 2, 100 plus topics mentioned by examiners. So all of these have been updated and they're available now on the eMedica website. I'll just show you where you'll find them. So if you go to the eMedica website, emedica.co.uk, here's our AKT. So stats, you see this blue button here? This allows you to subscribe to either just stats, just admin, just clinical grammar 1 and 2, or the bundle, which includes all of them, is near the bottom, gives you at a discounted price. For those of you sitting in July or later, we will have live sessions for these running That's where the live dates are for. So you can see stats, the next live one will be 18th of May for people sitting the exam in July. And we've got one in September for people sitting the exam in October. Okay. But the live ones for April have already happened. The recordings are available now. Okay. Right. Time for the mini mock. We're going to do 10 questions, 55 seconds per question, but the questions will move forward automatically. I won't launch any polls after each one. I'm not going to stop and explain each one. You're just going to do all 10, one after the other. So write down your answers at home. After we've done all of them, then I'll go through answer and explanations. Okay, so here we go. First one's kicking off in 2 seconds. Okay, great. So we're going to go through the answers, explanation, and teaching. Mark, you're on. You get 1 mark for each correct answer. And I'll remind you about how multiple best answers are marked when we see one during the exam. Okay, so question number 6. Very common to get at least 1 cancer pain type calculation in the exam and 1 pediatric dosage type calculation, at least, okay, in the exam. Sometimes you might get more. So what we're looking for is the most suitable dose for this patient who's changing from oral modified release morphine to syringe drive. So is on 120 milligrams twice daily, i.e. that's 240 milligrams in total in a 24-hour period of oral morphine. And we're now going to swap, because they can't swallow, to a syringe driver. This is very common. So what's the most suitable dose? The correct answer is C, 80 milligrams over 24 hours. That's because a conversion, when converting from oral morphine to a syringe driver with diamorphine, is 3:1. So i.e. add up the total that they need in 24 hours, 120 milligrams twice daily is 240, and just divide by 3. So 240 divided by 3 is 80. Common mistakes with this, sometimes people know that the conversion is 3, but they see 120, they miss BD, and so they get 40 milligrams. Far too low a dose. They're going to be in significant pain. The other thing that might lead people to losing marks is that they get 120, BD is 240, but their knowledge isn't there in terms of that the conversion is 3, and they divide by 2, so they get 120 milligrams. That's the conversion if you convert it to not diamorphine, but morphine by syringe driver, because morphine by injection is twice as strong as morphine by tablet, by mouth, okay? So this is directly from this exact table is in the pain relief in palliative care section of the BNF. So syringe driver is particularly useful for patients near the end of life. If you're converting from oral medication, calculate their 24-hour oral morphine requirement, including any breakthrough doses. This patient didn't need breakthrough pain, but let's say they had some oral morph for breakthrough, you'd add that up as well. And then if you're converting to morphine, divide by 2. If you're converting to diamorphine, divide by 3. So this patient was on 240 in total, 120 BD. If you're converting to morphine by tablet, sorry, by syringe driver, you just divide by 2. But because it was diamorphine, it was 80. Let's say someone was on 60 modified release twice daily, 120 in total. Morphine would be 60, diamorphine would be 40, and so on. Okay. Okay, genetics. So we've got carriers for hemochromatosis who are second cousins, and they want to know the risk that the children, if they have any, would have the disease, not be carriers, but have the disease. So how's hemochromatosis inherited? That's the first part of this that you need to know to get the answer correct. What's the inheritance? Autosomal recessive. Yeah, perfect. Okay. So therefore, the correct answer is 25%. Okay. Can you see they're both carriers? That means they've both got 1 normal gene and 1 hemochromatosis gene. So if both parents are carriers and it's an autosomal recessive disease, there's a 1 in 4 chance that you have full-blown disease. The second one in the set, if they're both carriers, they want to know what's the risk one of their children become a carrier. That's 50%. Okay. And this is true of any autosomal recessive disease. I'll show you an image that makes it hopefully clearer. So look, these are the parents in that scenario. Mum has got 1 hemochromatosis gene and 1 normal gene. Dad has got 1 hemochromatosis gene and 1 normal gene. You get 1 from your mum, 1 from your dad, right? So if you're unfortunate to get the hemochromatosis gene from mum and from dad, 1 in 4 will have full-blown disease. There's a 50-50 chance that you get the hemochromatosis gene either from mum or from dad and a normal one from the other parent. You become a carrier. And there's a 1 in 4 chance, so 25%, that you get the normal gene from mum and the normal gene from dad. You're now, not only are you not a carrier, you can't pass it to the next generation for a recessive condition. Okay. So that's the inheritance for autosomal recessive diseases when both parents are carriers. And it's also worth knowing the modes of inheritance of the important and relatively common genetic disorders for the UK population for this exam. And I've listed them there for you. You'll get the topic review when it's ready, so you'll have this information for later. Okay, so oligomenorrhea, question number 9. Now, this is a multiple best answer. Can you see it says which 2? Most questions they'll just say, what is the right answer? Or, what is if it wants you to pick more than one correct answer, it will state the number. So you can see it says, which two of the following? But this is also a negatively framed question. The majority of questions in the exam are positively framed. They'll ask what you should do. What is the diagnosis? What would you prescribe? What would you test? Okay. But you may get a few questions in your paper that are negatively framed. You can see it says, which two of the following would not be recommended as part of the diagnostic workup for this patient? So if you miss this, I've put it in bold. Sometimes it will be highlighted in some way, bold or capital or underline, but sometimes it won't be. So it's a matter of just reading carefully. That's part of exam technique. Now, in a multiple best answer, you have to get it fully correct. So if you get one right and one wrong, you get no marks. There are no half marks in the AKT. You have to get it fully right to get the answer. So again, it's a two-step question. The first thing, what's the diagnosis? What is it that we're looking for? Based on this scenario, so you've got this young lady, she's under 40, erratic periods. They're very changeable, then had no periods for 3 months. Then they started again, got some mood changes, not on any medication, otherwise healthy. What we'll be thinking about is premature ovarian failure, or premature ovarian insufficiency is the other name for it, okay? Because of the age, she's under 40, okay? So which two would not be recommended as part of the diagnostic workup for that condition? Correct answers are A, pelvic examination, and H, anti-Mullerian hormone, AMH. Now, what commonly happens, a lot of people get this one right, because people think, I haven't ordered this test, and so this is probably not something that I'm going to be doing. But a lot of people don't pick this. And so if you get one right and one wrong, you get nothing. There are no half marks in the AKT. All right. It's specifically not recommended to do a pelvic examination or AMH as part of a diagnostic workup for premature ovarian insufficiency. Okay. If you look at the description, no change in weight, recent smear was normal. You haven't got any reason to do a pelvic examination because of specific red flags. You shouldn't do it just because you suspect premature ovarian insufficiency. All right. So when to suspect it? Under 40, not on the combined pill, and they've got menopausal type symptoms. That could include infrequent periods or no period for a while, spontaneous resumption. And what you're looking for is raised FSH. So 30 international units per liter or more on 2 samples, at least 4 weeks apart. And other things that you might do, LH, so LH, FSH are the gonadotropins, estradiol, prolactin, TSH, testosterone, but you shouldn't routinely perform a pelvic examination, and you shouldn't use AMH testing as part of that diagnostic workup. Okay. Question number 10. So this question's about GMC guidance. So in relation to GMC guidance, GMC got a specific section on guidance about gifts. And it talks about when we can and can't accept gifts. So which two are correct? The correct answers are B and F. Again, you need both to get the mark. A lot of people get one of these, but they get the other one wrong because a lot of people incorrectly pick E, which has got nothing to do with GMC guidance. Why might they pick E? Because they sometimes confuse GMC guidance with the GMS contract. GMS, General Medical Services, is one of the 4 NHS GP contracts. And doctors working in a GMS practice, there's a specific clause in that practice that high-value gifts should be reported and recorded in the register of gifts. But that's got nothing to do with GMC guidance, which is what this question's about. GMC guidance doesn't specify at all what type of gifts, in terms of if you can accept money or vouchers. They don't say anything about that. They don't say that you can't. Equally, they don't specify any value of gifts that needs to be reported. That's a completely different topic. You see, like, we're all bound by GMC guidance. Only those of you that work in a GMS practice are bound by the GMS regulations, not related at all. So common mistake, either not having covered that topic or not reading carefully, and therefore getting one of these wrong and getting no mark. Okay. So unsolicited gifts, you can't ask for gifts. You can't pressure people to give gifts. But if someone gives you a gift and you didn't ask for it, there are certain circumstances where it's absolutely fine to accept it. And they don't set any maximum value. So what the GMC says is when we can and can't accept gifts. So, you're not allowed to encourage gifts. You can't pressure patients to make donations, even if it's to charity. You're not allowed to alter the management you offer based on gifts. And you shouldn't accept a gift if it might be seen as a conflict of interest or you're trying to take advantage of a patient. Like you've got a patient with dementia, don't accept a gift from them. All right. They might feel they have to give you something. They have to pay you for the service, that you've done a home visit, for example. Okay. But as long as none of those apply, then it's given freely. Unsolicited gifts can be accepted. And the GMC doesn't specify any maximum value. They don't specify that you can't accept gifts in the form of vouchers or money. They don't specify any of that. Okay. Now, if you happen to work in a GMS practice, which is the most common NHS GP practice, that's nothing to do with the GMC. They have a clause within that high value gifts should be recorded, and they consider high value gifts worth £100 or more. But that's nothing to do with the GMC, which is what this question was about. So again, the importance of not just having knowledge of topics, but reading the question carefully. Exam techniques really, really important. It's very easy to misread this as GMS if you're in a rush. And you've seen 55 seconds isn't very long. You can feel pressured, right? Question number 11, rheumatological disease. So the key thing here, this patient might have rheumatoid, right? Persistent synovitis of unknown cause. And the key here is that it's affecting the small joints of the hands and feet. So we've given us some painkillers, ordered some blood tests, so, probably put them on some NSAIDs. What's next? Correct answer is A. They should be referred within 3 working days without waiting for the results. We've ordered them, but don't wait for the results because that's going to delay. And that's because anyone with suspected rheumatoid should be referred within 3 weeks. But patients with specific high-risk features, they should be referred within 3 working days. One of those is the small joints of the hands or feet being affected. And this patient has both. Okay. So anyone with suspected rheumatoid, refer to rheumatology within 3 weeks. Who to refer ultra urgently? Within 3 working days. Small joints of the hands or feet are affected. More than one joint affected. Or they've already had symptoms for at least 3 months, i.e. they're likely to already have significant progression of disease. So we want them to be seen quickly to get on disease-modifying anti-rheumatic drugs. Because things like NSAIDs that we can give, they might help with a bit of swelling, they will help with pain, but they're not going to arrest the progression of the disease. Okay, that's why we don't delay referral for waiting for the blood tests to come back. You just do the referral straight away. Okay. Alcohol intake. So we've got a drinking history from this teacher. They're having a 250 ml glass of wine at 12% alcohol by volume, 7 nights a week. So that's every single evening they have this. But this is the tricky bit. On Saturday and Sunday, they have another large glass with lunch each day. So how many glasses of wine does this patient have in a week in total? Type into the chat. 9. Yeah, excellent, right? So 9 glasses. And if you know that a large glass of wine, 250 ml at 12% alcohol by volume, that's about medium strength for wine sold in the UK. If you know that that's about 3 units per glass, 3 times 9, 27. Okay. So about 3 units in a large glass. If she's having 9 of them, 27. Common mistake, people just see the 7. They don't add the extra on Saturday and Sunday, and they do 7 times 3. And so they get 21. That's a common mistake. Let me show you the formula if you want to calculate it precisely. So units of alcohol is the volume in milliliters multiplied by the percentage alcohol by volume. Take that total and you divide it by 1,000. So look, 250 milliliters, that's the volume, multiplied by 12% alcohol by volume. And then you take that total and you divide it by 1,000. I'll show you on a calculator. So 250 mils multiplied by 12% alcohol by volume gives you 3,000. Divide that by 1,000. That gives you 3 units. Multiply that by the number 9, because she has 9 glasses. That's our 27 units. Okay, so multiply that number 3 by 9 glasses, 27 units. You get the same exact figure. So if you can learn how many units are in common drinks, sometimes you can estimate and you'll be close enough to the right answer and can do it quite quickly. But it's worth knowing the formula so that you can calculate it precisely if you need to. So wine at about 12%. A 250 ml glass is 3 units. A small glass, 125 ml, like the small one that someone might have in the house, that's 1.5 units. Beer, standard strength beer is about 3.5%. A pint of that is 2 units. Premium beers and lagers, 5 to 6%. A pint of that's about 3 units. Spirits, 25 milliliters of any spirit at 40% alcohol by volume, which is a common strength of spirit sold in the UK. That's 1 unit. Sometimes that's described as a single pub measure or a single shot. And cider is often strong. So a pint of cider, often similar strength to premium beers and lagers, so about 3 units. But if you want to be precise, take the volume in milliliters, multiply it by percentage alcohol by volume, take that total and divide by 1,000. That's how many units is in that drink. Okay. Worth noting that 1 pint is 568 milliliters. Because sometimes they might describe it how a patient would describe. Patient's not going to say to you, I have 568 milliliters 3 times a week. They'll say, I have a pint or half a pint. Do you see what I mean? So if they describe it like a pint is 568 milliliters. Okay, question 13. So you've got this patient with poor diabetic control. They're already on triple therapy, metformin, sitagliptin, pioglitazone. But look at their HbA1c. Type into the chat, what's the level when someone's on multiple drugs like this, where you say, look, the control is not good, we should think about going to the next step. What's the threshold to add treatment? 58. Yeah, well done. Okay, so you can see they're way above that. They're 70. So what we're going to do is we're going to put him onto insulin. What would be a suitable initial regime? Correct answer is B. Start him on NPH, neutral protamine hagedorn. This is taken from fish proteins, okay? Insulin, and continue with the metformin, okay? And what I would probably do for a patient like this, I put them on this once daily to take in the evening, and then that's going to provide them, it's an intermediate acting insulin. It's going to give them a baseline throughout the day, and then they've got their metformin, haven't they, in the day. When might we consider using detamir rather than an intermediate acting? Detamir or insulin glargine is another option. These are long-acting insulins. You might use these if the patient is described as having lots of symptomatic hypos, or if they can't manage the injections themselves, they need help with them, so having a longer acting one might be easier for them, all right? But there's no suggestion of that. When might we go straight to adding in NPH and adding in a short acting if this was 75 or more, i.e. if it was much worse controlled than it is now, you might go straight to 2 forms of insulin. So something as a baseline and then a top up around meal times. So NPH is one of the intermediate acting insulin. You can start them on a once daily. That's common to start on the evenings and they continue their metformin in the day, or you can do it twice daily. So 1 in the morning, 1 in the evening. And then if that doesn't work, you can add in short acting insulins doses around meal times, bolus doses as top-ups, basically. Generally, you would continue the metformin and you would usually stop the other oral anti-diabetic medications. But you could, depending on the specific patient, you might look at maybe stopping one of them and keeping them on 2. Generally, though, if you're going to put someone on insulin, you'll just keep them on the metformin. I've already mentioned that if their control is really poor, so HbA1c 75 plus, you might go straight to NPH and a short-acting insulin. And you might consider long-acting insulins if they need help with injections or they get lots of hypos with other formulations. And then once they're on insulin, of course, we've got to monitor blood sugars a lot more frequently than when someone's on oral medication. So you typically measure it morning and evening. And if it's not well controlled, that's when you might think, do I need boluses around meal times and things like that? Okay, so this is an example of a free text question. There's no options of A, B, C, D, E, F, G to guess from. In the exam, you would use your keyboard to type the answer. So type your answer. We've got answers ranging from as low as 2.5, 4, up to as high as 415,603,901. Okay, so big spread. So the correct answer, and the only answer that would get you a mark, is 41,560. Okay, 41,560. Now, some of you actually calculated it absolutely perfectly and you will have got 41,560.39. You would not get the mark for that. Even though that is the exact amount, the reason you wouldn't get the mark, look what the question asked. It asked for the incidence of COVID-19 per million to the nearest whole number. And so if you wrote it to a decimal place, even though that was perfectly exact, there's no mark for that. It goes to exam technique. Good example. You could have the knowledge of how to calculate what they're asking you to calculate. But if you don't follow the instructions, you may not get the mark. So this is the only thing that will get you the mark. Now, if you didn't put the comma, that's fine. So if you put 41560, you'd get the mark. But any other number but this, 41,560, there will be no mark for it. So let's go through the calculation. So the question is asking about incidence. Can you see here, the COVID-related deaths, that's irrelevant. It's a distractor. This would be relevant if they asked for COVID-related mortality, because mortality is about the number of deaths, okay, per so many of population. Generally, mortality is per 1,000 of population, okay? But the question is asking about incidence. And so for incidence, all we care about is new cases. So these are the new cases, okay? 2,770,000 new cases. This is actual data. And the population at that time was 66,650,000. So incidence is the rate of new cases. So what you do is you take the number of new cases, divide it by the population. That gives you the rate. This is it as a decimal. Now, you can quote incidence as a percentage or as a rate per so many head of population. Even percentage is actually just per 100 population, because percent means per 100. So it's always per something, right? COVID incidence worldwide, the WHO, to compare from one country to another, they requested data from each country per million. That's why this question's asking it, because that's how the public health data was presented. Okay, you'll have seen, remember they used to have the daily updates. You'd see comparisons between different countries, okay? And so in this last step, once you've got this figure, you've got to multiply by 1,000,000 to get it per million. Whatever it's per, like if you wanted it percent means per 100, then you do per 100. That's where some of you got this wrong. Some of you multiplied by 100. If you did that, you move this two places, you would have got 4.1, which to the nearest whole number is 4. That's why those of you that got 4, what you got is 4%. But the question didn't ask it percent, it asked to the nearest whole number per million. So you need to multiply by 1,000,000. So if we do that, we get 41,560.39. Again, some of you got this. Well done. Your maths is right. You've got the knowledge of how to calculate incidence, but you wouldn't get a mark for that because the question asked it to the nearest whole number. Because you can see 0.39 people can't get it, right? They've just asked it the whole number to make it easy to give out for the broader population to find it easy to compare. People understand whole numbers. So 41,560 people per million were getting cases of COVID at this time, right? So this is what you'd need to write to get the right answer. Now, why is it 41560, not 41561? To round to the nearest whole number, after the dot, you look at just the first number. Ignore this line. If this number here is 5 or greater, then this will become 41561 because you'd round up when it's 0.5 or higher. If it's 0.4 or lower and it's 0.3, then you round down, then this is the whole number, 41,560. Okay, so to recap, incidence is the rate of new cases of a disease. You can either report it as a percentage means per 100 of the population, or as a different proportion of the population, like per 1,000, per 100,000, per million. And generally, we look at it over a year. Like 1% per year means 1 in every 100 people per year. 2 per 100,000 per year is the same as 0.002% per year. Do you see why this is easier for people to understand for things that are less common than this? So all you do, take the number of new cases, divide it by the population. Then if you want it percent, multiply by 100, because percent means per 100. If you want it per 1,000, multiply by 1,000. If you want it per 100,000, multiply by 100,000. In this case, we wanted it per million, so we multiply by 1,000,000 in this last step. Okay. And last question, prescribing in pregnancy. So patients come to us second trimester and wants to know about using NSAIDs. You know, you can buy ibuprofen over the counter, can't you? So the correct answer is D. Based on a recent MHRA alert, So MHRA is the Medicines and Healthcare Regulations Agency. They are the people that regulate, authorize, approve drugs and medical devices to be used throughout the UK. They also recall when things are found to be unsafe. So if someone wants to get a drug listed in the BNF, able to be prescribable in the UK, they have to go through the MHRA for authorization. They also publish each year safety alerts because they're always monitoring. You know, when you fill in a yellow card about someone who's had an adverse drug reaction, you send it off and the MHRA analyzes this. And so they will often put out updates about important drug safety notices. And these are frequently tested in the exam. So this was a recent one, okay, from last year. So they advise now, remember historically, it used to be 28 weeks. Now they advise 20 weeks. So they've always been, you know, considered to be contraindicated in the last trimester from 28 weeks onward because of these risks. Closing of the ductus prematurely, renal dysfunction in the baby, prolonged maternal bleeding, impacting contractions during labor, leading to prolonged labor time. And it could be oral or injected, it should be avoided. So ibuprofen, naproxen, diclofenac. But you see, this latest data highlights increased risk are now from 20 weeks onwards, not just 28 weeks. And so what this data has shown, that prolonged use after 20 weeks can lead to reduced fluid, so oligohydramnios, because it can cause fetal renal dysfunction. It can cause constriction of the ductus, which can lead to heart dysfunction. And so they now say that we should consider antenatal monitoring for oligohydramnios if the mother was exposed to NSAID for several days or more after 20 weeks or 20 weeks onward. And that's if they were already taking it, because people can buy it over the counter. Like, we should ask about it. And we should absolutely avoid prescribing NSAIDs after 20 weeks and advise them to avoid buying it over the counter. Okay. So add up your total. You got 10 questions from the mock, and we did 5 one at a time before that. So you get a total out of 15. Add up your total. I'll tell you how to interpret it. Okay. Then we'll talk about what to do between now and the exam. So if you've got 11 or more, well done. That would be a pass in any historical sitting of the AKT. Because the highest the pass mark has been set in the past is 72%. And 11 or more would take you above that. If you've got 10, that's borderline. In some sittings, it will just scrape a pass. In some sittings, you just miss it by a couple of marks. Because the lowest it's been set is 66%. 9 or less, that wouldn't be a pass at the moment, but don't worry. You're not sitting the exam tomorrow. You've got, if you're sitting in April, 6 weeks. If you're sitting in July, you've got months, all right? And whether you got 9, 10, 11 or more, the main purpose of this session today is to revise some topics maybe that you've read but missed out some of the details, to consolidate knowledge about things that you might not know, the guidelines change, or like a recent MHRA alert you might not be aware of, and to work on exam techniques. So all of you, what I want you to do is take from these questions, and they're hard questions. We deliberately did that because the purpose of this evening is learning, right? Is look at every single question that you dropped a mark. Why did I drop a mark? Is it that I haven't covered that topic? So, okay, if I've got gaps, I need to go and do the reading. I need to learn the material so that I don't leave gaps in the curriculum. Is it that I knew the topic or the guideline, but I misread the question, or I misunderstood what the examiner was asking? I missed that it was negatively framed, or that, you know, I missed this one keyword, some of the finer detail. Is it that actually you just needed a bit longer time, and maybe that's something you can work on? Maybe you haven't done that many questions at a time. A lot of you at this stage, you might not have done that many timed mocks. That's okay. It's important that you do those as you get closer to the exam, okay? But ultimately, what I want you to take from this is, let me fill in any gaps in my knowledge and let me work on my exam technique, because if you want to pass the exam, both are important, right? So let's talk about revision planning for the last 6 weeks of the exam. By this stage in your preparation, if you're sitting in April, you should have already covered a good chunk of the curriculum. What you need to do between now and the exam is systematically cover any gaps, any weaker areas in the curriculum. And then make sure you've covered stats, admin, high yield clinical, but as you get to the last 2 weeks, revise all of the key stats topics, all of the key admin topics, and all of the high yield clinical topics, because these things are frequently, stats and admin are always going to come up as 10%, 10%. So stats will be 20 questions, admin will be 20 questions. High Yield clinical topics, a good 30, 40 questions in your exam will be based on the High Yield clinical topics. As we get closer to the last month, the last 30 days before the exam, I'll post a video each day in our Facebook GP training support group. The team will post a link to that. Please do join if you're not already a member. Please do go through that. It'll only take you 5-10 minutes, but it will be like the first session where there'll be a question, 55-second timer, then an answer, explanation, and some teaching, a rapid review. And then work on your exam technique. So you can do that by, continue to do practice questions, but also as you get closer to the exam by doing timed mocks. I recommend you do, one timed mock every week, the last 4 weeks before the exam, to get you exam ready, to expose you to lots of topics, but build on answering questions correctly to pressure of time, okay? If you want to make sure you've not missed any important topics in the curriculum, you can download our AKT curriculum checklist. This will come out to you in the post-course reading. When the recording is ready, I'll send you an email with the links. Those of you on our pass guarantee program, you already have this, okay? And then after each examiner's report is published, I look through and see, are there any new topics that are not already on my list of high yield topics from all the past examiners' reports since the AKT started being run? And then I update it. So again, you can download the latest version to make sure that you're not missing any of the high yield topics from the checklist. Now, if you want to read a specific guideline, you can look up NICE CKS or the full NICE guideline. If you're short of time and you want to cover lots of them in a short amount of time, you might find our clinical case cards helpful. So we've got 112 topic reviews mapped to the same things that your questions are about. And there's a printed version, printed on high quality card, easy to carry around. You can read one in between patients. Where relevant, we've sourced and licensed high quality images to help your learning. There's a digital version available which you can access from anything with an internet access, tablet, phone, and there's a bundle that includes both. Okay. So that can help you cover lots of things, quickly. And, it's up to date. The latest edition was published late last year. And then, how we did the second section where you did 10 questions in a row, and then we went through the teaching without the polls and rapid reviews. If you found that helpful, we ran recently, this last weekend, our AKT 200 question mock grammar, where we did a 50 question mock like that, 50 questions in a go. Then I went through answers, explanations, and you got a PDF download with a topic review. Then had a break, then another 50. Then after lunch, we repeated it again twice. So by the end of the day, in one long day, it's over 8 hours, we covered 200 topics, 80% clinical, 10% stats, 10% admin. And then there's access to another full online mock with 200 different questions afterwards. So the recording of that has been updated and is now available. I'll show you again that same, we looked at our website earlier, emedica.co.uk. So within that, in the AKT section, see AKT 200 question crammers there. So if you click subscribe down here, you've got an option of just the 200 crammer on its own. That's here. Or if you want the 200 crammer and the stats, the admin, the high yield clinical 1 and 2, they're available as a bundle at the bottom, okay? And then for those of you sitting later, the live version of those will be running again before the July exam in May and June, okay? So we've got, for those of you that are sort of preparing for April and maybe want a boost, we've got the masterclass bundle, which includes the stats, admin, high yield clinical. Got the booster bundle, includes all of those and the AKT 200 and the full online mock. We've got our AKT Pass Plus bundle, which includes all of those, 3 full online mocks, our online question bank with, in total, including the mocks, 2,700 plus questions, printed clinical case cards, and our full day AKT preparation course and half-day masterclass that we ran in February, the full day course before the AKT 200. Got different questions, 3 teaching mini mocks. So all of those are available from our website in the AKT section. And all of them offer discounts compared to buying any of these things separate. I want to make sure that we wrap up with this really important message. This is from Muhammad Ali, that don't count the days, make the days count. we are now coming into the most critical part of your preparation. These last 6 weeks, do not let a single day pass you by that you haven't practiced some questions, that you haven't revised some guidelines, that you haven't gone over some of your notes that you made from your earlier preparation, that you haven't maybe explored one area that you feel less confident in. Try to build in learning into everything that you do. So you see a case, whether that's on the wards, if you're in hospital job, you could think, okay, when that patient was referred in, what would the GP have been looking for? Let me learn the guideline. For those of you in GP, every time you see a patient, think, what can I gain from this? What could be a question that they could ask? It could be about the red flag. It could be about what things present with. It could be about how to make a diagnosis. It could be about the management guidelines. It could be about specifically the prescribing. Read up on those things, okay? Every single day, every interaction, try to take some things away from it. And then on top of that, proactive, practicing questions, doing mocks, reading, revising guidelines. Don't let a single day go by that you're not making progress towards your goal of improving your knowledge, improving your technique, being exam ready. If you can do that, 6 weeks is a huge amount of time. If you make every single day count, come the exam, you will be ready, you will be prepared, you will succeed.